Our presenter tonight is Dr. Forrest Tennant. Dr. Tennant is going to talk about intractable pain in Ehlers-Danlos. He has been treating chronic pain patients since 1975, and he specializes in the research and treatment of intractable pain at the Verac Intractable Pain Clinic in California. He has authored over 300 scientific articles and books, including a handbook for pain patients. He is a member of the American Academy of Pain Medicine, the American Academy of Pain Management, and American Pain Society, and American Society of Addiction Medicine. So with that, I'm extremely excited to introduce Dr. Tennant.
Let me say, first off, I am delighted to be with you. Number two, I started treating intractable pain. It wasn't called that at the time, but it amounted to the same thing. And I started back in 1975, starting a clinic as part of the Los Angeles County Health Department system. And I primarily at that time treated cancer patients and polio patients. And I never dawned on me, frankly, at that time, that Ehlers-Danlos even was associated with pain. And I, like other physicians over the years, came to realize that I had patients in my clinic who had EDS and many times were undiagnosed. And at this point in time, I put EDS in the category of being in the top 3 or 4 most severe pain problems. A lot of people, for example, think that cancer pain is the worst of pain, but let me assure you that many EDS patients have pain far beyond any cancer patient I've ever seen. And so it's one of the pain problems that is severe. It's been very troublesome. Many physicians are afraid of the disease and of the kind of pain that EDS patients have. At any rate, I have come to in some ways, I guess, subspecialize in treating the pain of EDS patients, and I do want to pass on to you what I have learned. Let me say right out front that this presentation is not designed so much for patients as it is for physicians. I say that because if you are an EDS patient and you have severe chronic pain, you will have to know more about what to do and what it's about than 99% of physicians. And so I'm going to cover the latest in science and the latest in clinical treatment. And I was asked particularly to talk about hormones, and that is because I've gotten known for my hormone work. I was an internal medicine and endocrinology specialist many years ago, and I've kind of carried that over. But I learned some years ago that you could not control intractable or severe pain without certain hormones, both for replacement as well as therapeutics. And I'm going to cover that. And I do believe that the EDS patients need to be very, very familiar with this. Now, the thing that I want to talk about first off is why EDS patients have such severe pain. And the second thing I want to cover is the new concept of centralization. Every EDS patient needs to understand this because it is the concept of centralization that is not well understood by the medical profession yet, because it's fairly new relative to research, and those of us who are very involved, we're very familiar with it and comfortable with it, but it is a new subject, but one that I want you to know about. So I'm really going to teach you tonight what I know about it, and really almost as to what physicians must know, because a lot of you are going to have to go educate your physicians and other medical persons. You have a rare disease relative to a condition such as just simple lumbar sprain, for example, or arthritis, and so having a rare condition, you've got to do a lot of educating of your own physicians in order to get good help. At any rate, the first thing I want to talk about is from a pain perspective, why EDS patients have, a severe condition. So the real problem with I'm just not quite sure how these slides are going because it's not going like I wanted it to there. Now I've got what I want here. The problem with EDS is that EDS patients can't turn off their body and can't turn off pain signals. And as you know, you can start literally in childhood having pain with EDS. And it is the constancy of the pain signals going from a damaged joint or damaged cartilage or damaged ligament that go to the central nervous system and end up resulting in what we call today centralized intractable pain. And the term centralized is a term meaning the process of pain doing what we see with phantom limb pain, and that is that the pain goes into the central nervous system, causes inflammation, and then embeds itself or implants itself permanently in the cells of the central nervous system. On this next slide shows you a schematic diagram of how this occurs, and this is almost universal among EDS patients. Now, it all starts out with a peripheral nerve injury. Centralization can also start with something like head trauma, for example, or stroke, or a disease such as encephalitis that gets into the central nervous system. But in most EDS cases, the initial pain is in the periphery, meaning it's outside the brain. It's in a hand, it's in a knee, it's in a hip, it's in a joint somewhere. Now, this signal, this pain signal from this injured area enters the spinal cord and the brain, and it causes something called microglial activation. Now, I suspect that knowing EDS patients as I've come to know them, most of you stay right up on things. You're trying to be as learned as you can. You're on the internet. You're reading. You're talking to other people. And so a lot of you, I know the term glial cell or microglial cell. Now, microglial is the cell in the nervous system that is really a white blood cell. It is an inflammatory cell. It is the cell that is in the spinal cord and the brain that causes inflammation. And inflammation, we now know, is caused in the spinal cord and in the brain just like you can have inflammation in a joint. Put another way, most EDS patients are familiar with having inflammation in a joint as well as in their spinal cord and in their brain. But it is neuroinflammation as it is caused, which is the real problem. Now, with neuroinflammation, and all of you are familiar with what inflammation happens to be. All of you have had a boil. All of you have had a red joint. You're familiar with inflammation being hot and painful. And at any rate, in this process, you have a release of toxins. Now, these toxins will cause cells to start dying, tissue to start reforming, scars to form. And the real problem is that pain can get imprinted or implanted in the cells. And at this time, we do not have a cure for this condition. Now, a lot of people are making false claims that they may be able to cure pain that becomes centralized, but at this time, there's no hard scientific evidence for it. I know a lot of patients, including some EDS patients, that darn near have cured themselves. And one of my goals here tonight is to give everybody hope and bring you up to date on some of the work that I'm doing. And the work I'm doing is very helpful and hopeful, because I'm seeing people getting results, reducing their pain to levels that I never hoped would be possible. I'm seeing people reduce their opioid levels down to rock bottom. In other words, I don't want to sound too missionary, but I'm extremely optimistic about the things that we're seeing today for EDS patients. Now, I want to talk about the criteria for the clinical diagnosis of centralized pain. This comes from an article that will be published in the next 2 weeks in Practical Pain Management. I just led a task force of physicians and with some nurse practitioners, podiatrists, and pharmacists to come up with a consensus, if you will, on how practitioners should diagnose centralized pain. And I would like to have every patient know this, because as you look at the next slides, I would ask all of you to ask yourselves, do I have centralized pain, or do I have just peripheral pain, or do I have some of both? But it's critical for you to know if your pain has centralized. If it has centralized, then you're going to need to go about dealing with your pain in a different way than if it simply is in the periphery. And by in the periphery, I mean you have some pain in your knees or your hips or your shoulders, for example, but it has not yet entered your spinal cord and brain and implanted itself in those organs. Here is the essential elements of centralized pain. Now, I would ask everyone watching this webinar to take a look at these four elements. If they apply to you, then you have centralized your pain. Number one, you've got to have a peripheral injury or disease, and EDS patients, by definition, have this because you have painful and inflamed joints. But the big one is constant pain. If your pain is there all the time, it never goes away, it's there 24/7, then you probably have centralized pain. If your pain is there only on some days or on some hours of the day, you do not have centralized pain. But the hallmark of centralized pain is pain that is there, that is constant. Now, we used to call this intractable pain, and we still do, but we really technically refer to it as centralized intractable pain. Now, the other thing one has with centralized pain is sleep interference. In other words, it's hard to get to sleep. You may get to sleep, but the pain wakes you up. The pain may be severe enough you can't get to sleep, but one way or another, it interferes with your sleep. And then number four, you have fatigue. In other words, even though you got a good night's sleep and you have the right diet, the right attitude, you're still fatigued. And so those are the big three: constant pain, sleep interference, and fatigue. Now, there are some other supporting symptoms that patients with centralized pain may have, and here is a list of those. And we're telling physicians that if you have 7 or more of these 15 symptoms, then that's very good supportive evidence that you have centralized pain. Now, I would ask everybody watching this to run down that list. And I'm aware that many of you, if not most of you, will have a great number of those symptoms. In other words, part of my goal here tonight is to let you know that you're looking at yourself in these slides and that you have company, and that a lot of these symptoms that you have are real. They don't mean you're crazy. They don't mean you're disturbed. This means that you have microglial inflammation inside your spinal cord and brain. And then a lot of people, for example, will take a look at this and they realize sometimes that they have funny smells, or they can't remember anything, or they're depressed, or they just can't function some days. They spend most of their day in bed, for example. These are all signs and symptoms of centralized pain. Another thing that centralized pain does is activate two major physiologic systems inside the brain. One is the hormonal system, and the other is the autonomic sympathetic nervous system. And what that means, that is the stimulatory side of the nervous system, and its technical name is autonomic sympathetic, but you don't need to know that. But what we're talking about here is that these 9 physical signs may be a result of centralized pain. In other words, your centralized pain is like a battery sending out too much electricity, it causes your body to have hypertension, your heart rate to step up, you sweat all the time, your reflexes are too active, mydriasis is a dilated pupil, and you get vasoconstriction, which causes your hands and feet to be cold a lot of the time, or other parts of your body to be cold. And what's funny about it, sometimes you can have awfully cold hands and feet, but yet you've got a temperature that's 103 degrees. So you get this hyperthermia at the same time you have cold extremities. And hyperalgesia just means that if you push on your joint that is inflamed, it hurts worse than it should. And allodynia is just the pain that is there if you just barely touch the skin or wave a feather on it, you may cause pain. So these are supportive physical signs that I'm asking medical personnel to look for and patients to know about relative to determining whether their pain has centralized. Now, there is no specific diagnostic test for centralized pain. However, Patients that have centralized their pain almost always have hormone abnormalities, and they will have elevated inflammatory markers. Now, it's a little hard to get the inflammatory marker test today, but there are some that pretty well diagnose the presence of centralized pain. And I've just finished some studies on this, and it's not necessary to take them to make the diagnosis or to guide treatment necessarily, but they're nice to have if one happens to be a little uncertain as to whether the pain is centralized. Now, the hormone abnormalities I'm going to talk a lot more about, because the hormone abnormalities may end up with having hormone deficiencies, which then require replacement. And so EDS patients have to know a lot about hormones, both the testing as well as what it means. And the exciting thing about it, there are some what we call neurogenic hormones that are being used to investigate the ability to literally start bringing about some healing of pain in EDS patients. When it comes to the hormones, just quickly, when you have centralized pain, there are two phases to its effect on hormones. The uncontrolled pain, first off, causes hormones in the blood to go up. Therefore, you have elevated hormone levels, and those include such hormones as cortisol, estradiol, progesterone, corticotropin, pregnenolone, and some others, which I will show you here in a minute. And then if the pain is not controlled, then your pituitary gland and your adrenal glands and your gonads may start to deplete. And when that happens, pain gets worse, your pain medications aren't very effective, and you'll be miserable because in order to have any kind of comfort, hormones have to be in normal range in the blood. This is a little complicated, but it's a picture that I would like for everyone to know about. What it shows you in the middle are three overactivated microglial cells. And if these cells are overactivated, they cause all of the things you see on those arrows. And I'm well aware that many of you watching this can go around that circle and see that you have yourselves a great number of those symptoms or those manifestations of microglial cell overactivation. Patients for years have told me things, and I believed them, but I didn't know what caused it. They've always told me they had memory loss or insomnia or fatigue or depression or decreased attention span. We knew that their hypothalamic and pituitary was overstimulated, their sympathetic nervous system was overstimulated, and we knew that they certainly came in seeking a lot of drugs for relief. And unfortunately, a lot of people who have this microglial cell overactivation try to find medical relief or try to find relief through drugs, and they're usually called a drug addict or given some other pejorative name. And I'm trying to get the medical profession to understand when they see a patient who has a lot of these signs and symptoms and constant pain, not to look at that person as a drug seeker or a drug abuser, but somebody who needs help and needs an evaluation for centralized pain, as well as other things such as hormone deficiencies. And I'm calling, if you will, for a new day, and that is quit looking at people as drug seekers, but understand that they have overactivated microglial cells. You might find it intriguing, but today we are starting to use the term microglial cell modulator. There are a class of drugs that are being investigated and, in fact, being used clinically today, which calm down these activated microglial cells. Some of them are actually antibiotics, some are hormones, and some are other agents. But one of the new areas of treatment is a class of drugs that we are starting to call microglial modulators, meaning we change or we modulate the activity of these microglial cells to reduce the inflammation and reduce the pain and to increase healing. I thought I would throw this in to make a point about something. We have had in recent years controversies. We have a group of people who are trying to ban opioid drugs in the country. We have a group of people trying to ban epidural injections. We have a group of people who say that pain is all in your head and only psychotherapy should be used. But we have a long-standing standard in pain treatment that's been here a long, long time, and it is still the gold standard, and that is the World Health Organization three-step analgesic ladder. I would like to have all pain patients know about this ladder because this is how you treat people, and this is how you deal with things as to whether somebody needs a higher dose of morphine than someone who needs a lesser dose. In other words, step one in pain treatment is non-opioid pain relievers and adjunct therapy. This means that the first thing you do when you have pain, and an EDS patient certainly needs to know about this, this is where you're going to use exercise, you're going to use topical medications, you're going to use what we call neuropathic agents, you're going to use electromedical things, you're going to use prolotherapy, you're going to use all these things that are not opioids to see if you can control the pain. One of my pet peeves is that I get patients referred to me, and nobody's ever taught the patient how to do exercises, nobody's given them topical medications, nobody's ever told them what nutritional supplements they should take, nobody's told them how to take care of themselves without narcotics or without opioids. And if you aren't making it on these non-opioid therapies, then you need to be given an opioid. And we have two classes, the weak ones and the potent ones. And the weak ones today would include such things as tramadol or codeine or Vicodin or Percocet or something like that. And then if that doesn't work, then you add a potent opioid. You don't give up your topical medications and your TENS units and your exercise. You add to this regimen. And this is the way it's supposed to be practiced. And we've been doing this since the 1980s. But we have an awful lot of naysayers and a lot of people who are trying to deny and state that there is no standards, and that gives them an excuse to either deny people an opioid or to give them too many when they haven't done non-opioid therapies. In other words, we've had this standard since the 1980s. I've been practicing it since then, and I'll continue to do so because that is the gold standard. Patients who have pain need to understand that there is this standard, and if you don't have a copy of this, you should get a copy of it, and all the medical profession needs to, give up the rhetoric and all the condemning of this, one treatment or another, calling people names, and putting this ladder to work. So I wanted to make it clear that good, serious physicians who deal with pain are aware of this ladder and are going to support it. They're not just going to give you an epidural block or a shot or something like that and send you on your way. They're going to follow this as they should. I now want to talk about hormones because this is my area of research, and I've been the one in the country trying to popularize this. And here is why I'm big on hormones, and I will continue to be big on hormones because pain control is hormone dependent. Hormones are needed for four things. First off, tissue healing. You cannot heal your joints if you have a deficiency of one of the major hormones in your body. Hormones help heal joints. There's some new research out, for example, that things like estrogen and testosterone are critical for the growth of cartilage. Secondly, reduction of inflammation. Inflammation is controlled by a lot of different factors, but one of them is hormone control. Again, if you don't have enough hormones, your inflammation is simply not going to calm down. I mean, the classic inflammatory hormone is cortisone, but there are others that are almost as necessary to control inflammation. So cortisone is not the only hormone that one must have to control inflammation. Analgesic effectiveness. Now here is one that's very unappreciated. Drugs such as hydrocodone, oxycodone, morphine, fentanyl, all of the opioids are dependent upon adequate hormone balance to be effective. Most of you have heard about receptor sites. Now, receptor sites are little action points in the nervous system, and a drug such as Vicodin, for example, or Tramadol or morphine will bind or attach to these little receptors, but the receptors don't work if you have a deficiency of hormones. In other words, you can't get good pain relief if you don't have enough hormones, because all major pain relievers, particularly opioids, only work when you have adequate hormone balance. And then lastly, neuroprotection and neurogenesis. These are new words. They have recently come forward. 5 years ago, no pain specialist would even have ever uttered the word neuroprotection or neurogenesis. But neuroprotection means that you're going to keep what you have. You're going to prevent any deterioration of your current neurons in both your brain and your spinal cord, or even out in your legs or arms or joints. That is neuroprotection. Now, the body produces a number of hormones to give you neuroprotection. And then secondly, the body has something called neurogenesis. This means you're going to take a nerve, a neuron, and make it grow. It is nerve growth. Now, hormones are required for both of these. There is a fascinating and absolutely essential bit of research that has come out of the recent years, and that is that the brain itself produces its own hormones. They are called neurosteroids. This might shock you, but our own brains produce estrogen, progesterone, pregnenolone, and something called DHEA, plus it produces something called oxytocin and human chorionic gonadotropin. Now, those 6 hormones are used by our nervous system to not only give us neuroprotection, but they are in our brains to give us neurogenesis, in other words, nerve growth. If you have centralized pain, you must be on a program of pain relief, number one, but number two, you're going to have to be on some kind of a hormonal program that keeps enough hormones in your nervous system to make sure that your nerve cells are protected as well as make some grow. It is the growth of the nerves that allows one to reduce their pain permanently, or at least almost the whole way even sometimes, but at least reduce it, and this, therefore, you need far less medication. So these concepts of hormonal control of pain are critical. And this is one of the things that I want to leave you with today, is that this is the new understanding and the new wave of treatment. I would not want to be doing pain management today with intractable pain cases or with EDS patients without the ability to both test and treat with any number of hormones. Now, today, something else has happened which is wonderful, and that is laboratories throughout the country now have the technological ability to do hormone profiles. Now, literally 3 or 4 years ago, if I wanted to get these 8 hormones tested, I'd probably be filling out laboratory slips for a month and begging laboratories to try to run these tests. Today, you can go to any of the major laboratories, and your physician can fill out a simple one-page request form and request these 8 hormones. This 8-panel hormone profile is what I recommend today. There are actually 2 laboratories that have sprung up in the past year that actually cater to pain specialists to do hormone profiles, and more laboratories are on its way. In other words, we could not have I couldn't even be giving this lecture tonight if laboratories had not developed the technology to do this hormone profile on a single tube of blood. So I do want you to know that hormone testing underpins all the hormone treatments, and that the technology is here to have this panel done rapidly in every community in the United States. Neuroprotection. I wanted to put this on here because I get asked all the time by people who don't live anywhere near my clinic, which happens to be in Los Angeles, but I get asked about this all the time. So I thought I would throw this little slide up. This is a little handout that I give all my patients, and I give it to anybody who wants some help, because a lot of people, I am aware, cannot find good medical help in their communities. I think it's a travesty that we don't give good care in every community, but in case you know somebody or you yourself can't find good help, taking some of these things on the slide will at least keep you going. It'll at least give you some neuroprotection, keep you together until maybe you can find some good help. Now, I'm not saying you got to do everything on that slide, but you certainly want to try to do a handful of the things that you see on this slide. And you can buy all these things in a health food store. You don't need a prescription, and this will give you some relief. Let's say you're in some treatment now and you feel you're getting some pain relief. If you add some of these things to it, you just enhance the pain relief you are now getting. I want to close out with this last slide. On this slide are some areas of clinical investigation. Now, when one does a profile like the one I just had on the previous slide, and you have deficiencies of some of those hormones, they need to be replaced. But today, there are two areas of investigation that I want to tell you about. They're very exciting. And I have some EDS patients who are certainly benefiting by these things. The first one is high-potency topicals. Now, what does this mean? This means that these three hormones, when put in high concentrations in a cream and put on your joints or over your nerves, will not only give you good pain relief, but start to, we think, cause neurogenesis. Let me tell you about a fascinating study that was recently done. Some very bright researchers took cartilage that came out of knee transplants. In other words, when you transplant a knee, you open the knee joint and you scrape all the loose cartilage out of the joint, and you normally just throw it away, and then you put the metal in and you sew them back up. But at any rate, some bright researchers took this cartilage and they put it in the petri dishes, and then they started putting different chemicals on the cartilage to see what made cartilage really grow. And guess what the two things were that made them grow the best? Estradiol and testosterone. And so today we are giving a lot of patients today high potency estradiol, progesterone, and testosterone to rub over their sore joints. And I have some EDS patients, and I hope some of them are actually watching, who are using some of these high potency topicals. Again, it's a comer, and I think it's of great interest to EDS patients. And the second thing that I want to bring to your attention is neurogenesis and microglial modulation. These two terms I mentioned earlier. But there are two hormones that are starting to change the lives of a lot of people with centralized pain. Human chorionic gonadotrophin is the hormone that the body apparently uses to grow nerves. For example, a pregnant woman will have human chorionic gonadotrophin go way up in the serum, and it used to be thought that it was just there to maintain the placenta, but we now know that it is that hormone that is responsible for the growth of the nervous system in the embryo. And so all of us, when we were in our mother's womb, the chorionic gonadotrophin that was produced was there to make our nervous systems grow. And so that's what it does. That's its natural function. And both men and women have human chorionic gonadotrophin. And we're learning how to use it more and more. We have some patients who have been on this compound as long as 5 years, and they continue to improve their physical systems and they continue to reduce their pain. And the last hormone I want to mention is oxytocin. We're not 100% certain how it works, but EDS patients certainly like oxytocin as a group. There will always be some people who will not care for it, but it has at this point been a very helpful hormone for EDS patients. And I highly recommend it that people give it a trial. Most physicians in the country have heard of the hormone, but they really don't know how to obtain it or what dosage to use or what to look for. But I'm hoping that some of that will get changed in the next year or so.